It doesn't look like a huge It doesn't look like a huge agenda, but I think there might be some conversation points, and I want to make sure that we allow for plenty of space for conversation, basically. So thanks and welcome everyone for coming. Raylene and Brian, I don't know if you have any thoughts on who wants to do what in terms of getting us fired up here and started. Raylene, do you want to do that or Brian?
I can do it.
Okay, you just want to go through and do the all through the land acknowledgement, and then I've got some things to say.
Okay.
All right.
This is the Behavioral Health Committee meeting on December 16th at 11:30. Before we begin, we acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge that we have been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider these many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events. And I would just say we should take a moment and keep people in Sumas, Nooksack, Everson in our thoughts with all they're going through, dealing with the recent floods. So our first item is the Digital Leak Wellness Center. Dan, did you want to give us an update on that?
Yeah, there's a couple of things I wanted to touch on real quick before we dive into the agenda. One, it looks like there's a Scrivener's error. It says, or at least on my copy of the agenda, it says September agenda before the land acknowledgement. That should say December. I think it was just a holdover from a previous. So just heads up, we'll get that corrected. Um, let's see. Jill, are the Deep Leach folks on the call here? I can't see them.
I'm not seeing anyone from there yet.
Okay.
I'll let you know if I see someone pop in.
Okay.
Um,
I just texted Bev Keys. She's the executive director. She says apparently not, don't know what you're talking about.
So I see a hand raised, Bryce in our attendee. Maybe that's someone from Digwalik. Would you like me to allow speaking?
Yeah, definitely for Bryce.
Okay, Bryce, go ahead.
Oh, thank you. I just didn't get a panelist link, so I was only able to join so far on the other way to join the Zoom.
And are you representing Digwalik?
Yes, I'm the Chief Medical Officer of
Okay.
Village Wellness Center.
I'm just promoting you right now to panelists, so you can share your screen. Thank you, everyone.
I see Chris Curtis also has his hand up.
Yeah, let's bring Chris in too. He's the Whatcom County manager for the MMUs.
Thank you.
And what I wanted to do, Chris and Bryce, before you guys get started, I just wanted to do a quick go around because we got a variety of folks from different organizations here, and I just want you to get to know them very briefly, so
Great.
you know who your audience is. Just gonna go across the screen here. Peter, do you want to go?
Sure. Peter Fraser, co-chair of the Incarceration Prevention Reduction Task Force.
Thanks, Peter. Wendy Jones.
Wendy Jones, I retired from the sheriff's office as the jail chief, and I'm a citizen representative now.
Thanks, Wendy. Dr. Wu.
Ying Wu, a retired family physician and an intern at the Chuckanut Health Foundation.
Thanks, Doctor.
Thank you.
Raylene King.
Raylene King, Whatcom County Superior Court County Clerk, co-chair Legal and Justice Subcommittee.
Thanks, Raylene. Cedric.
Cedric Johnson, here as a community member. In my professional life, I work with community health centers.
Thanks, Cedric. Danny Carroll.
Good morning. Danny Carroll. I am the MSW Program Director and faculty for social work at Western Washington University.
Thanks and welcome, Danny. Brian Estes.
I'm Brian Estes, co-chair of the Behavioral Health Committee, and I'm on the board of directors of NAMI Watcom.
Thanks, Brian. Pam Jacobs.
Hi, I'm Pam Jacobs. I'm the Behavioral Health Director here at Unity Care Northwest.
Welcome and good morning, Pam. Dean.
I'm Dean White. I'm a part-time special projects manager for the Health and Community Services Department, the Response System Division.
Thanks for being here, Dean. Stephanie Kraft.
I'm Stephanie Kraft. I'm the Superior and Juvenile Court Administrator.
Welcome, Stephanie. Melora.
Morning, everyone. Melora Christensen, Health and Community Services. I'm the Response Systems Manager.
Excellent. Stephen Traff.
Stephen Traff, Homeland Security. I'm just a community panelist.
Thanks, Stephen. Welcome. Eric Ritchie. Eric might have stepped away from his desk. Okay, well, let's Dan Hamill, Bellingham City Council. I'm the co-chair along with Brian Estes for this Behavioral Health Committee. And like Brian said at the onset or at the top of his remarks, this is a joint meeting between behavioral health and our legal and justice systems for the task force. So Bryce and Chris, the floor is yours for the first agenda item. And just maybe you want to introduce yourselves and your role with the clinic and just let us know what's going on.
Great.
Thank you.
Thank you, Dan, and thank you all for your time and sharing a little bit of updates from what we're involved with. My name is Bryce Parent. I'm a family physician and addiction medicine physician, chief medical officer of Dequal Leach Wellness Center. And Chris Curtis, would you like to introduce yourself?
Good morning, everybody. I'm Chris Curtis. I'm an SUDP. I'm the interim manager with Dequal Leach with the Division Street Clinic and our new Flora Street Clinic.
Awesome.
Chris.
Yeah. So Bryce, go ahead and take it away.
Great. So we'll share a few updates and a few asks about ways our community can engage with us. And so our two locations, as Chris mentioned, are now on Flora Street at the First Baptist Church and on Division Street next to the Ann Deacon Center and the Sheriff's Facility. And we're offering addiction treatment, including methadone and buprenorphine for opioid use disorder, as well as addiction counseling, both individual and group, and access to our broader array of services at our Anacortes location, both by providing folks transportation down for things like dental care, primary care, mental health care, as well as telehealth for services that are telehealth appropriate, like mental health care, hepatitis C treatment, et cetera. And Chris can share a bit of our patient numbers and recent trends, and then I'll share a bit more.
Thanks.
So at Division, we're seeing about 59 clients total on our roster, and about half of those folks show up daily for services. At Flora, we seem to be building traction much faster than we did here at Division. We've got about 19 clinics on the roster, and we're seeing at least half of those folks daily. So in operations, we don't really think in terms of capacity or use waiting lists. We just try to meet a need where we see it by increasing our staff. And it looks at Flora that we're probably going to need to expand our staffing soon. So that's good. And I'll turn it back over to Bryce, and he can talk about some of our successes.
Thanks, Chris. And part of that, what Chris mentions that about Flora Street is, as many of you may know, we've only been open there a bit over a month. So that's a quicker trajectory of welcoming new clients there than at our Division Street. That's plateaued in recent months at our Division Street. So some of our successes so far since opening our Division Street location earlier this year and then expanding have included good staffing levels, which allows close follow-up with our clients. Excellent security staff allows us to keep our locations safe and clean. Excellent ability to admit clients on a walk-in basis, Monday through Friday in the morning. And as Chris mentioned, we're grateful we haven't encountered any need to have to turn folks away. We've been able to be adaptable and welcome everybody in who would like services. And we have also, our addiction counseling team offers one-on-one and group counseling and case management, and they're able to offer a high level of services to those who want to engage more, and sort of an understanding approach of we're there for you to folks who want to engage less. So that's a nice flexibility there. And we're offering transportation services that again fits the theme of flexibility, that have been adaptable to where we see folks in the community in need of this treatment who are enrolling in our services and need transportation into clinic. We've added routes based on where there's need, and that has included as far as Nooksack and Everson, and as well as transportation to, as I mentioned, to our broader range of services in Anacortes, and adding telehealth availability of certain services when we saw a need for that. And some folks choose to come all the way down to Anacortes for our fuller range of services, dental and otherwise, and other folks just access what's available by telehealth since that's more convenient, like our mental health services. And as far as some challenges, we'd be glad to be serving more clients. We're grateful for everybody who walks in the door that we're able to work with in their recovery path. But as Chris said, we're adaptable to admit more folks if community members in need are able to get in, if we can get the word out more. And then another issue that is no surprise that we have been encountering as an organization for years in different ways is stigma against methadone. So that's something always to sort of keep stigma reduction on our mind and in our conversation. And so one of those things that I think is important in that sort of pairs with stigma reduction is that everywhere that treatment is recommended for opioid use disorder, all three of the most life-saving options should be recommended: methadone, buprenorphine, and long-acting injectable buprenorphine. And we appreciate that there's so much that's vital in recovery, and that varies person to person, and it's well beyond just methadone and the different forms of buprenorphine. But we view those medications as the life-saving foundation on which to add all the other elements that are important to someone's recovery journey, but that it's much harder to help someone on their recovery journey if we're not able to help them stay alive long enough and engaged in treatment long enough to benefit from everything else that's vital in recovery. And with that, I think it's common in various parts of our systems of care to offer what you have most accessible. But I think it's important in many care settings and social service settings and public health settings, when we're in a conversation about connecting someone with treatment, to consider all the options, because we know that buprenorphine is an outstanding tool, but it doesn't work for everybody. So keeping all the life-saving options in those conversations is important. And then again, help in getting the word out. And in another stigma reduction aspect is there's been more research in recent years about how, unfortunately, there's a lot of good intentions with abstinence-only treatment, but there's been more research coming out about how that path in treatment is fortunately not, on average, when you look at a population level, on average, not a life-saving path. There's recent research that shows higher rates of death when folks engage in abstinence-only treatment. So keeping that in mind in our stigma reduction conversations, that we focus on helping folks stay alive and in treatment long enough to benefit from everything that our region has to offer on the recovery journey. And we wanted to present that those basics, and then welcome any questions or discussion that would be helpful.
Sure. Thanks, Dr. Parent. Chris, did you have anything to add to that, or before the questions come?
No, just that if I was to ask any help from community members, it would just to be to spread the word that we have medications for opioid use disorder, and we're happy to collaborate with any other uh, community agencies to help increase the success of their current clientele and patients.
Okay. Okay, thanks, Chris. I see some hands up. I'm gonna call them in order. Wendy Jones.
Just a real quick question. Are y'all able to do folks who have substance use issues and mental health? So if co-occurring was the old term, I don't know if it's still being used, but I know that population is the highest population that accesses the jail. So
Um, yeah, I'm happy to speak to that. Chris, do you want to speak to that as well?
Go for it.
Okay. Sure. Yeah. Yes. Essentially, we 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 try to be as welcoming and adaptable as we can with our. We have two psychiatric nurse practitioners and mental health counselors where they're at our Bellingham locations because they are mobile medication units with a smaller accompanying physical space. There's just we don't have as much ability to have all of our services there in person compared to our Anacortes location. So that's why I was speaking to the telehealth where folks say with opioid use disorder who also have mental health conditions, we would certainly offer them a ride, both medication and addiction counseling in Bellingham, and they could get a ride down for a face-to-face visit for mental health services at our Anacortes location. But we know for convenience that some folks prefer telehealth, so we can connect them with our mental health counselors and our psychiatric nurse practitioners on a telehealth visit from our Bellingham location. And with that, there tends to be a very short wait time for those mental health services compared to sort of average in the region. And that's a good thing for those that we serve as well.
thank you very much.
And Chris, do you have a sense of how long, when folks come in needing mental health services, how long it takes them to get their first appointment?
Depending on need and desire that person to engage, it can be very, very quick. It can be next day, within the week.
Thanks for the question.
Okay. Thank you, Dr. Wu.
Well, I have three things. First of all, I want to say this sounds amazing. And I'm hearing things like flexible transportation, short waiting times, all of which are not terms that I typically hear a lot in this scenario, which is really wonderful. And the flexibility, especially because it seems to me that you're running a scenario where you're adapting to the patient instead of us trying to jam a patient into a predetermined programmatic pathway, which I think works much better being patient-centered. I have two questions. One is a simple logistical one, which is if you were a primary care physician practicing in the community and you weren't yourself doing this kind of treatment or not doing it as comprehensively as you are, what's the best method for them to refer a patient to you? And would you also be open to co-managing them with their primary care physician if their primary care physician, say, for example, was already doing their medication prescribing but didn't have access to the counseling resources they needed? That's one question. And the other question is, which I'm sure many of us are wondering, is how do you manage to do this when it doesn't seem to be doable in other sectors or by other parties?
Yeah, thanks. So and part of when you talk about co-managing, part of what we see as common is that the majority of folks who come to us are self-selecting onto methadone. And of course, there's clinical decision making that pairs with the patient preference in that. But there's usually folks who end up at our doors are historically are usually aware of what we offer, and they've had some life experience where some form of buprenorphine, usually Suboxone, didn't work well for them. And so they're self-selecting onto methadone. And then most commonly than that co-management would be, say, that their primary care provider still being involved, still being doing their primary care, and we'd be doing, say, the methadone management and addiction counseling part of things. And we're absolutely happy to do that. And when it comes to referrals, most folks come in on a walk-in basis just by the nature of our patient population, but we're absolutely happy to receive referrals and prioritize those folks in our admission process, and we can provide appointments. It's just not our norm because our patients often not their flow of life. But yeah, does that answer the referral and co-management question?
Yeah, just the detail. Is there a form or a paper or is it a phone call or a fax? How do you want us to get that information to you?
Chris, do you want to answer that part of it?
Well, phone call is always helpful if we have a little bit of information. We have walk-ins daily until full, Monday through Friday. If the person can get to us and has the skills to walk in and advocate for themselves, that's preferable as well. A warm handoff is nice. We have an intake coordinator that if you call any one of our lines, either you can get to Bellingham through our main line or the Anacortes location through our main line and speak to an intake coordinator, and we can facilitate it pretty easily.
Yeah. So phone call is great. And then there was a second part to your question.
The second part was, how are you managing to do this when it seems so difficult for so many other groups and entities?
Yeah, I think part of that's, we have the tribe support, and we have an operation in Anacortes that has been doing this for much longer. So when we're opening up a new location that's in its sort of early wanting to get the word out, wanting to welcome more folks in and grow stage, it's able to be supported by the larger operation that's been stable for longer.
Great. Okay, we'll move along here. Peter Fraser.
Hi, Bryce and Chris. Thanks for presenting today. I've been very taken with the generosity of the Swinomish tribe in putting this program forward, even though here we are in Whatcom County. And it's a wonderful example. So thank you. I've got another hat that I wear, and that is a property manager of the Avalon Apartments, which is right across the street from your Flora facility. And I'm also a downtown advocate. If there were issues or problems, I might be one of the first to bring them up. But I have been really impressed with the way you guys are operating, and it is only a benefit to not only the community, the people themselves, but also to the neighborhood. So I really want to thank you for that as well.
Thank you.
The only concern that I've had is uptake. You guys have been doing this for some time, and I know you have a lot more capacity. What's the issue, really? I mean, I'd be very interested in hearing you two talk about, are there issues with marketing or word of mouth or communications? Are there other hurdles or blockages in our countywide system? What can we all do to get as many people to your clinic as possible? So thanks.
Thank you. Thank you for your comments. I'll share an initial thought and welcome Chris's thoughts as well. One thought that comes up is when, with the clients that I've admitted to our Anacortes program over the years, I commonly ask them what brings them into clinic and how they hear about us and why they choose us. And by far, the most common answer is that it was word of mouth from someone that they're personally connected with, a friend or family member who shared with them that they personally had a positive experience with the care of Deedwal. And so that's something that comes to my mind as something that then is that kind of thing is more gradual to develop, right? And so early on, I see a need for more getting the word out efforts while we don't have that as much in Whatcom County as we have sort of the word of mouth spreading already in Skagit. And Chris, do you have thoughts to add to that?
I agree. Yeah, word of mouth. I feel like if we can help one person become stable in their neighborhood, that's our best advertisement for continuing services for other folks. And I hear that all the time. We bring in one person, and pretty soon we have multi-generational treatment where we have entire families that we're serving. So we kind of plateaued the end of this summer, and I think that was a combination of us losing access to I don't even know the current state of the encampment where we're near here. Kellogg and Toll Road was that back access route. So we lost access to that, but we were really bringing in a ton of folks from the encampment areas. And it was also a combination of our outreach efforts. We took a different track when we opened Flora, but it's really just access to treatment, and it's just us meeting the individuals where they are. So it's if a community member sees a person that they feel is ready to engage in treatment and they can be connected to us, that's the magic, where the magic happens. It's just access.
Thank you. Brian Estes.
Yeah, I wanted to follow up and echo the comments of Dr. Wu about how patient centered this care is, and it's such an incredible resource for our community. So thank you for providing this. I guess my question is related to Division Street. What kind of improvements could be made in terms of transportation to help people access that facility? I don't really have any suggestions. I'm just kind of throwing it out as an issue to consider.
Yeah, Chris, do you have
Yeah, it's a complicated answer to a complicated question because every individual's situation is so complicated and personal. I don't know if there's a broad, and that's kind of why our philosophy is a philosophy of flexibility, because one person, we'll start a transportation route for one person. If we know one person needs treatment, we will change our route to get them on our transportation. Because like I said earlier, if that one person will begin engaging and become stable, they're our best advertisement for the services we can provide. But it's just connecting that person to us to initiate that intake process and get them on our transportation. We can do that wherever they are. But the answer for that person may not be the same answer for the next person that comes along. So it's the constant collaboration and um, being a bridge for that person between them and us. So whoever that person, whoever that bridge can be, I'll take it on any day.
and Dan, do you and part of the what this what comes up to my mind with this transportation question was one of a variety of motivators in us opening the second location on Flora Street to have options for folks that are more accessible. But Dan, do you have any further comments on, say, bus routes to the area and how that's been looked at? Because that's an aspect too, of course, is an that regular transportation that's available several times in the morning versus our routes usually are going to a particular location at one time, which we try to have be a time that works as well as it can for everyone. But obviously, there's value in the public transportation that's recurring as well.
Sure, I guess I can speak to that or try to. So WTA, which is our local transit provider, has one stop in front of 2030 Division Street, which is the location where that MMU is at, as well as Van Deacon Center. And one of the issues is that um, for certain parts of town, you'd have to hop on a bus and go downtown, transfer, and then go out to that location. So it's really, does a person want to spend, I don't know, an hour and a half on a bus, two buses to get there, depending on their location? So I think that that's a problem. To answer your question or try to, Bryce, yes, it's been looked at. I have a colleague on city council who's on the or two of them actually, pardon me, who's on the WTA board. They are well aware of the benefits that the MMU at Division can provide. And so, but changing fixed routes is more complicated, and I don't really know very much about that system. But yes, it's on the radar screen. Is it happening quick enough? No, of course not. But yeah, that's got to get fixed. But yeah, that was one of the reasons why Flora was such a great idea when it comes to let's bring the services to where people are at, geographically. And yeah, so I think between the two, hopefully we can get those numbers up to Peter and answer your uptake concern. Although, with Flora being open for just over a month and there's 19 people that are on the roster there, I think that's pretty good. Yep, and of course we need to increase those numbers. So, Melora,
Thanks, Dan. And I
sorry.
hope everybody knows my wasn't intending to give anyone a hard time with that transportation question. I just thought Dan might have a better update than I on that aspect of.
Sure. Thanks. I appreciate that, Bryce. Melora, oh, there you are. Okay,
Yeah.
sorry. Thank you.
Yeah, thanks, Bryce and Chris. This is so great to hear the update. I actually raised my hand to respond to the transportation question because I think some folks are aware that the Response Systems Division piloted a transportation behavioral health aide. We had that position for a year and a half. It was a full-time staff committed to transporting people actually beyond even Whatcom County if needed, when there wasn't another service to be had. Deepwell Leach, Unity Care, Sun House, public defenders, the jail, all of the response systems programs. Like, this was something that we used a lot. The reality is that we couldn't keep that one FTE busy. Even with this significant need where Colin would actually drive to wherever that person was and give them a ride. For the most part, he was busy about 50% of the time. And because of budget issues, we had to make the tough call that we needed to not fill that position when it became vacant. And that's really hard because I'm in meetings like this all the time where transportation is the crux. And we tried it. And even with making sure that that was open to every single provider in the community, like there was really the only time he couldn't transport someone was when there was a safety risk, but that was that rarely happened. And so I guess I just kind of keep, and I know this isn't about Digwall H specifically, but I think it is something for this group to be aware of, that we have this need, but it's actually quite specific, and it's not as large as we think it is. And so I don't know, Chris or Bryce, if you have anything to add to that, but I find that really fascinating because we thought he would just be slammed, and like wouldn't be able to have enough time to do all the rides.
Yeah. Thank you, Melora.
I was just gonna agree that, yeah, it's specific, and to build on what I was speaking about earlier, it's specific and the iron is hot and we have to strike when the iron's hot, but we never know when the iron's gonna be hot.
Okay. All right, moving along. Maya.
Hi. These questions kind of addressed what had initially raised my hand for, which is, we're looking at where we're going to place the behavioral care center, and if Division has tapered and plateaued, but Flora is a more prolific place to see people, is that really where we want to put our BCC? I don't, just putting that out there. And then as to the transport thing, we miss having Colin, frankly, and I recognize, but I would also say to that, Melora, that it might be like Deep Wellek, where it's a word of mouth thing, where it's like we were just starting to get into the rhythm of being like, oh, wait, there is somebody we can call to take this person somewhere, you know? And so while he may not have been at capacity yet, I don't know that he wouldn't have been had we had him for another year, because it's like, I mean, now we're bereft. So I don't know what's better. So I know you're not. I know you'd love to have him, and many would, but I just, I don't know. I do wonder if there is capacity for that work once we get accustomed to it being available. And now we are, but yeah, anyway, thanks.
Thanks, Maria. Melora?
And just for the record, if we were not in the financial situation that we are in right now, we would absolutely fill that position, because you're right, Maya. It's just a matter of time. But so we will come back to it.
And as far as the comment about location, we do have, and I'm sure some of you have heard this as well, that we have folks who comment to us that they would be happy to access our services, but either find the Division Street area difficult to get to, or that, which is part of why we're offering our transportation services, but doesn't answer the behavioral health location question that Maya was talking about. But then other folks who say that they're not comfortable in that area.
Is that because the work center is there and there's a jail facility so close, or just the weird sort of industrial zone that it's in?
I've heard some comment that about increased law enforcement presence.
Okay. Alexis?
I'm glad that was brought up, Bryce, because I was going to suggest that it's likely the proximity of the work center that's making people apprehensive to engage in a very intimate service there with their recovery. I can see that being a factor, and a good consideration when talking about the BCC as well. I did have a question as far as outreach efforts. Has there been any presentation to any of the local community colleges that are training folks in this work field for sort of that next generation of counselors? I found that with my own program at Men's Low Intensity Residential, we faced a lot of the same challenges at first, and now we've been at capacity for like the last 6 months. So it's a lot of that educating and then continuing to re-engage, and sometimes it has to happen over generations of providers. So I'm curious what those outreach efforts have looked like and if that's been fruitful.
You want to speak to that, Chris? Thank you for the question.
Yeah, it's a great question. Yeah, because when I did my SUDP schooling, it was a while ago, but there was no MOUD component. Now DeGualich has been incorporated into the MOUD education at Skagit Valley Community College, which is amazing and awesome. And we also have a relationship up here with Tori Sandos at Welcome Community College. So we've gone to the Human Services fairs and the upcoming substance use disorder. I can't remember the exact name of the week that occurs at Welcome Community College next month. So we'll be a present out there as well.
I'll see you there, Chris.
And just Alexis, it's for your edification on that question. So Tori is actually on this behavioral health committee. She just couldn't be here today. I think she's on vacation, so she's well aware. Peter.
I just feel compelled to say that by the time the BCC is built at Division Street, the work center would not be there. And so it would be a behavioral health campus without a law enforcement facility.
Thanks, Peter.
Hey, I was curious if proximity to where bringing services to where people are was also an attributable factor to the sort of rapid use of the Flora facility.
Chris, do you have a comment on your sense of that?
Nodding, sorry. I was being, sorry, nonverbal. Yes, I absolutely think it is. We're right there. We're doing outreach in the alleys and in the neighborhoods and introducing ourselves to neighboring businesses who are our de facto partners in this effort. So we do have a presence down there regularly. And I think that absolutely is best indicator of that success.
Thanks, Chris. Moore?
Yeah, and I would just add, I mean, the location is so ideal with Recovery Cafe right there and the way station being just a few blocks away and the bus station. I mean, it really is as low barrier as you could get. So I'm so glad that worked out.
Me
Thanks,
too.
Moore.
Thank you, Dan.
Brian?
Yeah, I just wanted to point out that kudos to Maura and there's a behavioral health and crisis services bi-monthly meeting, which a number of providers throughout Whatcom County attend. And the Dijwalik has been on that agenda, several times. So I just wanted to acknowledge that that's a continuing outreach through that bi-monthly meeting. I think is really important.
Thanks,
Thank you.
Brian. Dr. Wu?
Two things. I just wanted to echo what Melora said. I do street medicine shifts from time to time. We go to Recovery Cafe and so on. And it is so nice to be able to point people in a direction that is just a couple of blocks away where they can also get a meal, where they can also get treatment. It just makes a ton of sense. And the other thing I wanted to say is that I think there's a theme in a lot of what we're hearing, which is that uptake and recruitment is and retention are largely built on trust. And I think that's a really important lesson for us as we think about designing new facilities. I just always have this sense that for people who have not had a good experience in the justice system, I think it would be very difficult to heal in a justice system operated therapeutic setting. So while the justice system may be in a position to provide the physical facility, I feel pretty strongly that the criminal justice system is probably not the right provider for the healing services. And if we could have a provider for those services that operated on a trust basis, more like what Dijwalik is showing us as possible, I think we'd be much more likely to be successful.
Right, so Chris, you want to respond to that at all?
I appreciate that comment, and I agree from my experience. And as I was talking about the word of mouth, that trust is very central. And we have folks coming into our facility saying things like, "Oh, I've been to several different treatment centers and experiences and settings, and the difference here is you all care." And so establishing that trust is key.
Yeah, I don't have anything else to add other than that, yeah, trust is important. And that was one of the first things we noticed when we came up to this community was we're new, we're here. Who are you? Who are you? I may have seen your name before, I may have heard about you, but I don't really know anything about you. And we're in the individuals we're trying to serve, we're in their backyard as a stranger, and it's taken a long time to develop that rapport and to build trust. And that's part of, I think, why we're slow to gain some traction.
Thanks. Wendy?
Mine was real quick. I just didn't know if y'all had reached out to corrections. We get a lot of people who come into the facility and are medically stabilized, especially with substance abuse issues. But I don't know, because I've been gone for a couple of years, I'm not sure that our medical personnel and chemical dependency folks have you listed as an option, because we can give the information to the folks who are leaving. And, we tell them we're not going to follow up or anything. This isn't a requirement of the court, but this is a place for people who care about you and want to help you keep stabilized. So I didn't know if anybody had ever reached out to because a lot of times they don't think of the jail as a referring entity, but it can be very powerful. So it's something, if you're interested, the chief down at the jail now is Caleb Erickson. and I'm sure that he can connect you up to the medical staff.
Thank you. And I agree that's an important linkage. And we've had several productive conversations with Caleb. And so far, um, we're providing methadone doses to our clients and clients of some OTPs and other settings who end up at at our jails, and also in conversation about when the jail is able to turn on Medicaid in the last 90 days of someone's treatment, adding that component to admit folks to care who uh, in a more robust program in collaboration with the jail once that's able to get going.
Terrific. Thank you very much.
Thank you.
Melora.
Bryce, would you be willing to share with the group some of the good work that you've been doing with Pioneer Human Services and Detox? Because I think that's also a pretty exciting collaboration.
Gladly. Yeah, we worked with Pioneer Walking Community Detox, which of course we share a parking lot with, and are glad that we do because that has allowed us to work out something that's a new program for them and for our region, that folks coming into treatment there for opioid use disorder or for several substances, including opioids, used to have buprenorphine available as part of their treatment, but they didn't have a way to be started or continued on methadone. And we're able to be that partner for them. And so we've, depending on the individual client's needs, sometimes that's continuation of methadone while they're being treated for another addiction and receiving withdrawal management for that. And for many, it's a place to get started on methadone in a setting where, because they have 24/7 nursing team, we're able to get people's methadone doses safely up to a more therapeutic level much faster than we can in an outpatient setting where we don't have that, a nurse with them in the middle of the night making sure that everything is safe. So we've appreciated that partnership, and our patients have reported back much appreciating that. Chris, do you have comments?
I was just gonna piggyback what you said and say that because of that service, it's allowing people to access increased services more rapidly, because getting them to build up those strengths to where they can access increased services is a complicated and long process without the service that's being provided.
Okay, Melora.
And I just would like to add and emphasize that it shows what can happen when we have a behavioral health campus with concentrated various services in one location. So this is an example of that type of collaboration would not happen if they weren't sharing a parking lot. I mean, maybe we could figure it out, but it would require transportation and it would, right? But because we have three providers actually, but we are able to make that happen in pretty quick time. And so I do find it as kind of some affirmation that we're thinking in the right way when we're thinking about trying to have multiple services in one location. I know the division location is not ideal, but this is, I think, an example of how it is working.
Thanks, Melora. And I'll briefly comment as well. Some folks have mentioned meetings that are good for us to be a part of. If there are some where you don't see us present but think it would be helpful in our effort to get the word out and collaborate with partner organizations, that if you don't see us there and you think it'd be helpful, please reach out. We're glad to collaborate.
Thanks, Bryce. Before we wrap up with this agenda item, three new members have joined us, and I just wanted, and two of them have already spoke and have asked questions. I just wanted to provide some space for Maya, Kyle, and Alexis. So Maya, just want a brief introduction, who you're affiliated with.
Sure. Hi, I'm the Chief Deputy at the Whatcom County Defender's Office. And thank you so much for your services.
Thank you.
Kyle, I think that we can guess who you're affiliated with, but you just want to maybe mention who you are.
Yeah, my name is Kyle Nelson. I'm with the fire department. No, so yeah, just apologize about being a little bit late. My meeting that runs adjacent to it ran a little bit late, so I apologize. I was highly interested in hearing how the new facility on floor is going. So it sounds like it's going well, though.
Excellent. Thanks for joining, Kyle. Alexa?
Hi, Alexis with Lifeline Connections. I'm the program director for the men's low intensity unit, just over on Gerard. So
Awesome.
Thank you.
Thanks for joining us today. Bryce or Chris, any closing things that you guys wanted to say?
I wanted to thank you, Dan, for as we've worked out what it takes to offer these services in the community. We've much appreciated collaborating with you in the steps along the way.
Thanks. Thank you.
And I appreciate everyone in this group in all the diverse ways that you contribute to serving the community, and we're glad to be a part of the effort with you.
Thank you.
Yeah, all I would add is thank you very much. Thanks for the platform and the questions and allowing us to present.
Excellent. Well, it was clear that there were a lot of questions, and people are really curious about how things are going. And you'll definitely be invited back for an update later next year. So thanks for coming and presenting. We appreciate it. With that, I'm going to move us on to our next agenda item, and that is going to be Cedric, who will talk about. Let me just look real quick here. This is Cedric Johnson with the data work group, and Bryce and Chris, you're more than welcome to stay. We go until 1, but if you've got other obligations, just feel free to gracefully lead to step out. So whatever you want to do.
Thank you.
Yeah, of course. Cedric, do you want to go ahead?
Yeah, hi everybody. Just have a really brief update from the data work group. So as folks may recall, this is a joint committee or a joint work group of these two subcommittees. And we had put forward a couple of recommendations earlier this year, which really were sort of strong endorsements of the Village Reach projects, some of their top 2 recommendations, which were to hire a staff person and really start to build the staffing infrastructure to work on the data and reporting needs that are relevant to the IPRTF and to the Justice Project. And those were approved by these committees and then ultimately by the big IPRTF and forwarded to the County Council in October. And to be honest, we've faced a little bit of resistance since then. My sense is that folks from the county and from various stakeholders are broadly supportive of, yes, we need to, staff this appropriately, have the right people. There's a real acknowledgement that our data systems don't talk to each other and are probably inadequate. But then when, we have not gotten a commitment like, yes, we're going to hire this person. I acknowledge that these things do take time and that the county is facing a tough budget year. We've already heard some discussions about how budget and finances impact these projects. And so, at this time, we don't have a real concrete update other than to say that we plan to continue trying to, work these recommendations through the county, meet with elected officials as well as other stakeholders in the community. And then the other things we've been talking about, are looking at what our work might look like if this doesn't happen. What other projects we can work on, including perhaps increased collaboration with the index committee, and perhaps having folks from index committee join our work group or vice versa. So we plan to keep you all updated on that. Brian, looks like you have a question.
I guess it's more of an observation. When you think about 2 of the new electeds of Whatcom County, Jessica Reenstra and Elizabeth Boyle, both have mental health, work in the mental health field. And I was just wondering if it might be prudent to invite them to an upcoming meeting and just familiarize themselves with law and justice and behavioral health, and perhaps, talk about this specific recommendation, and maybe we could get some traction with the two of them to assist the council in maybe acting on the recommendation. So just a thought.
I think that sounds great. Raylene?
Thank you. Jill, can you let me share? Or actually, I think maybe I can.
Yeah, you should be able to share.
Okay.
If not, I've got it pulled up, Raylene. I can do that.
Okay. No, I think I'm good. So I'm just doing a brief introduction on this, Cedric. We had a presentation yesterday on a different group that does some data information, and we all want data. We all want tools that are able to show us what's working and what's not. But getting everything to talk to each other, making sure that things are able to be released is important. I don't know all the information on this, but there are some tools already in place that don't cost money. This one is accepted by AOC through the Washington courts, so you can kind of see that there's caseload information, annual protection order, disparity in criminal filings. And then it talks about more of that information. I'm not prepared to present on this. I don't have enough information on it, but I think it is something that it is worth looking at. So I'm going to end the share and come back to the group.
That's great.
And see if I can figure out how to do that. Okay, I think
and I want to acknowledge that we also have some great resources from the health department, and then we do have a couple of staff members who have been working for the last month or so on trying to get some initial information and data together for a data dashboard specific to this, to the broad data needs. And I see Dean, who's also on the data work group, has his hand raised. So Dean, do you want to jump in?
Yeah, first of all, I want to make note that Marty Solomon and Holly, get her last name, are working on the trying to survey in detail existing data available and at least begin the process of creating a preliminary dashboard. The other thing I wanted to just ask, Raylene, is could you provide a contact information? I'm assuming this is the Administrative Office of the Courts that did the presentation. Could you provide some contact information for us, some of us in the data work group, to reach out to and explore more what those resources are and what help they might provide?
Yeah, some of this has been vetted through the JISC, which is a committee that says who can see information and who can't see information through the courts. Some of this is already existing, so it is of less cost than some of the other options that we might be looking at. And by no means am I poo-pooing other programs, because I think that those are very important for us to look at everything as a whole. I'm just saying that we need to explore all of the options that are out there, and this was brought to my attention. So Stephanie and I spoke earlier about some of these things that are actually out there, and so this is from AOC. I did send a copy of this link off to Jill, so if Jill's willing to share that to everybody on these committees, I think that would be beneficial, and I think that we could possibly try to put some type of presentation with the Legal and Justice Committee or the next joint behavioral health to as a whole, and see if there's somebody willing to speak on some of the existing programs that are available through the court systems.
Yeah, thank you. That's fantastic.
Any other questions for Cedric? Okay. Seeing none. Cedric, did you want to add anything or any closing comments?
No, I think that's it. I don't know if Dean has anything else to add.
Okay.
All
Sounds
right. Thanks, everybody.
Yeah, thank you. Appreciate it. Dr. Wu, go ahead.
Just a couple quick things. I sit on the Racial Equity Commission, and we worked on some data analysis about the population of the jail. came to very similar conclusions, I think, to what Cedric and his team came to. And the thought occurred to me that maybe those two committees might want to join forces and work together to produce maybe a recommendation for the county council that would have another relook at this question, because I'm just really puzzled by how we can be proceeding with an architectural design program built on an absence of data.
Yeah, thanks for mentioning that. And I should have added, Miriam Karamoko, who's the executive director of the REC, has recently started joining our data work group meetings. They have been a fantastic addition. And so we are doing collaboration, and we look forward to collaborating with them more. And just to really amplify what you said, it is kind of remarkable to not have the staffing and focus on these needs. It seems like it's a perennial issue that is identified. And if you look back to the Vera report and some interim reporting that was done by WSU, and then the Village Reach report, it is a constant theme. So we hope to keep beating the drum about this. I see Melora.
I think Wendy was first.
Oh, Wendy, do you want to go? And Wendy is also on our work group.
I double checked, and there's aggregated data that anybody could access here through WASPIC. The most recent, of course, they've got is 2024, so last year's. And so that aggregated data, Dr. Wu, is going to be what the architects and everybody else is going to take a look at. The difficulty that anybody who's looking at projecting what jail needs are going to be is that all it takes is the state legislature to change one law, and it goes crazy, because either people will no longer be going to the jail, or one of the things that within my lifetime working at the jail, a big impact for us was when the state decided to change the categories of folks who would be going to prison. And instead, they redid the sentencing guidelines and said, well, if this is the offense, then they need to do their jail time versus going to prison, which prior to that, they'd been going to DOC. So that's one of the reasons, and some of the statistics are kind of mushy, I'll give you that. And certainly there are some other things that need to be looked at more carefully. But if folks are interested, I pulled the data off of online, but sometimes there needs to be some explanation of what this means. One of the things that I saw is that the category that WASPIC uses is Hispanic. And that's a question that the deputies ask folks, what do you consider yourself? It's self-choice. But we use at the jail, in our database, they're asked if they're Latino or Latina, and that's the category, but that's not the category that WASPIC picks up. So it looks like that we don't have anyone who comes from a Latino culture and that's who they are. So it shows that we don't have anybody in jail who may be Mexican, South American, or whatever. So those are kind of things that need to, if it turns out you all are interested, you can get to me through any one of the folks who chair. I can pull it up, and because I spent a lot of my time as the lieutenant and the chief explaining what all those numbers meant, it gave you some anticipation of understanding it. And the other last thing, and then I'll hush up, is that the county and I think the community is asking to be able to say, how big a jail are we going to need in 10 years, 15 years, and 20 years? The folks who do this for a living tell you, if somebody tells you that 10 years from now, your population, you're going to need this number of beds, is BS. That the folks who do it on a regular basis, who are architects and folks who specialize in this, they say if you can be accurate 5 years out, you're doing really well. And a big part of that is because changes in the legal system. And we can have this wonderful plan based on what the population has been, and then something changes and total chaos happens. So keep that in mind. It's going to be difficult to explain to people, the folks that y'all touch on, that this 20 years out, we're going to need these many beds. The current jail, which was the new jail when I started working, we had extra space for about 18 months. Law changed and we were taking people that we wouldn't take. Now we are back to the same situation it was when we transferred from the jail that was on top of the courthouse over to the new jail, which is they're telling law enforcement you can't book people. There's no space for these programs and that type of thing. So I guess I fibbed a lot. I talked a little bit more, but I'm done now. If any of you wind up with any questions, I'd be more than happy to answer it. Maybe not in this venue because I know we're running out of time, but you can always get a hold of me through probably Raylene or Dean, or I'd be more than happy to sit down and talk with anybody. Thank you.
Go ahead, Laura. Thanks,
Yeah.
Wendy.
I just, for context, I think folks know that the Response Systems Division, which runs 6 different unique diversion programs, we really want to be able to know, do those diversion programs make an impact for the individuals that they're in? Are people better off? Do we see a reduction of law enforcement interactions, emergency room visits, legal charges, right? We want to measure that, and we're doing that through data sharing agreements. Unfortunately, we made a lot of progress. I want to give kudos to how far we got. We just signed a data sharing agreement with the prosecuting attorney's office for their system, but we've struggled to execute the DSA with Bellingham Police and with Peace Health. And it's hard to navigate and figure out, well, if we don't have the data, we can't measure that. And again, this isn't population health. This is just for programs, right? But I think some folks have heard this in other meetings, but we are putting out a solicitation in January for a multi-year evaluation of all of the response systems program in one evaluation, because we want an evaluator to come in and look at not just each unique program, but how are they interconnecting. I wish we could do it for everyone in the continuum, but we have a very specific pot of money that we're using. And so we're going to have to keep it to just the response systems programs. But I'm encouraged because there's, the index committee, and there's this data work group, and there's Marty and Holly and the rec, and everybody's kind of circling around the same thing. And I think if we can start using the same metrics and the same, all be in some sort of similar lane about what we're trying to do and not duplicate or kind of, right? I think it will be really important, because this evaluation will just be one evaluation. It won't be something that continues on, but how do we just ensure that we're all kind of have the same vision around what we're trying to collect and what steps it's going to take to get there? So.
Yeah, thank you. Raylene?
I think it's really important that we look at the data and make sure whenever we present something that we also show that some of the data is skewed, that there are disparities, that when an officer arrests somebody, they may not give all their information to that officer. They may not want to disclose their race or their ethnicity. That officer is maybe having to run to another call. And so they're trying to get one done so they can get to the next one. And then they go into the jail and a corrections staff is booking somebody and they may give completely different information. And then the court's job is to put that information into the system based on the charging documents. We're not supposed to alter it, but we're also supposed to make sure there's person business rules that are required to be followed by court staff entering the data based on the information from the charging documents. So we're looking at 3 identifiers for a person. Today, I had staff go, hey, there's 2 well-identified persons for the same person. Which one am I supposed to use? And how do we link those 2? So we have to go to AOC to get direction to make sure we're using the right person. I said, well, where did we get the information when it was inputted? Was it an error? Was it a clerical error? And it turns out it wasn't a clerical error on the court staff. It was the charging document that had a different date of birth. And that could have been the date of birth that was provided to law enforcement at the scene, which could be an alias. So trying to link that information and then come back with a data dashboard that is reflecting disparities, racial equity, and information that is in the system also has to be done with the training of law enforcement and making sure that they're getting the information as best they can, as well as court staff and correction staff. And then you're still not going to always get it right because people lie. And that's why we have a court.
And it requires ongoing maintenance and updating as there are new systems and training. So I think that just one example from the court is huge and speaks to the enormity of this task. Well, I know we're really running over on time, so I think that's it from the data work group, but certainly folks can email any of us. You can get, if you don't know our email addresses, you can get a hold of us through any of the chairs or from Jill. We appreciate all the feedback and would be happy to hear from other folks about our work.
Thanks, Cedric, and thanks for leading the discussion on this today. We are getting close. We're about 18 minutes out, and we've got a couple of items here. Jill, do you want to go ahead?
Yes, thank you. There isn't a quorum of either of the committees today, so I would recommend that the discussion about meeting schedules be held to the joint, or excuse me, the individual committee meetings in January. Following the current meeting schedule, those dates are January 13th for legal and justice, January 20th for behavioral health, and I can notice both of those meetings as special meetings until a final annual calendar is decided upon.
Okay, I think that's a good call. I was actually going to see if we could switch the order, but I think that moving it to January is probably the better decision. So thank you, Jill. The fifth item here on the agenda is priorities for committees in 2026. I'm just going to toggle real quick here. So Brian and I had come up with a few priorities. I'll start with these, and Raylene, if your team has got some as well, we should invite that as well. So the four items that Brian and I came up with were to identify existing evaluations of pre-arrest, pre-booking, and pre-trial diversion programs. That's the first one. The second one would be to explore issues related to in custody versus out of custody mental health treatment. That's been brought up today. Dr. Wu, you brought that up. Third one is explore better integration between service providers at Division Street Behavioral Health Campus. The fourth one is looking ahead, envisioning how to use the existing work center at Division Street when it moves to the Bounty facility. And that would be pursuant to exploring a broader behavioral health campus and converting or repurposing that work center. So those are the four that we came up with. Brian, do you want to add to that?
Well, I think we should have a more thorough discussion about this at our January meeting with the Behavioral Health Committee. But I just wanted to say that the diversion and reentry work group, we really have not been meeting. And I was thinking that one thing that group might take on is number one, about what are the existing evaluations for pre-arrest, pre-booking, and pre-trial diversion programs, with the notion of what kind of data ultimately do we need to collect to evaluate or assess, how all these programs are working. So I just thought I'd throw that out there to the members of this our diversion and reentry work group, and we can talk about that more. Well, it would have to be at our next joint meeting, but for those people that are on the call, is there any discussion about that? Because I know we talked about previously the work group that, unless we have really best practices related to reentry or diversion, that we didn't think it was prudent to kind of tackle those issues. So, but Dan and I talked, and we kind of proposing this as an alternative focus for that work group.
Alexis, did you want to speak to that, or do you have other ideas? Or
A little bit of both. So in yesterday's IPRTF meeting, Peter brought up a component on defining terms. How can we measure something if we can't define it? And I think that's really pertinent to some of these smaller work groups and subcommittees. And I know that was a little bit of what we were feeling in that work group, Brian. Like, how can we define it? What are some other options in other counties that are being explored? And what would that look like for us? For me, it feels most important for us to really define reentry and diversion before we shift our focus somewhere else. Because for me specifically, I don't know what my intention is, what my role is in it, what I need to contribute if I don't have a little bit more of a concrete understanding of what direction we need to go and how we are understanding it as a collective. So, I mean, we haven't had a chance to chat, so sorry it's happening here, I guess, but I just wanted to get that out there in the spirit of defining other items as well.
Thanks, Alexis. Jill, I'm wondering if you could, if you haven't done it already, send these 4 items out to the committee or to the committee. Yeah, both committees, I think, but just so legal and justice can kind of have a heads up on, potentially what behavioral health is working on. But I want at least the behavioral health committee to have these items, so we can just kind of think about them and craft agendas around them as we move forward into next
Yeah,
year.
these items are in your packet for today, and I'm happy to
Okay.
screen share them if you like.
Um, yeah, let Raylene go ahead first, and if you want to then screen share, that'd be great, Jill.
Thanks. I was just, thinking as we're discussing these and you're putting these in the behavioral health, there's so much crossover between the two groups on pretrial services, reentry. I want to work with the administration and Superior Court on, I kind of brought this up, I think, at the last meeting, uh, self-help center. And some of the self-help centers that I've recently done some research on actually include reentry and navigators. But that hasn't been presented to the reentry group as a whole. And so I think that those are some other things that might overlap between both committees. But we also need to look at the data analysis on what we want for these things. So going back to what Alexa was talking about on clear definitions from these work groups on what we're looking for diversion. What is that definition? What is the definition for recidivism? And what are we looking for there? And then are we looking at information on what civil programs and health programs that are currently existing prior to somebody entering the criminal justice system? And are those working? Because we are always looking at prevention. And so some of the civil programs and making sure that children are getting the help that they need before they would normally enter the system. What data is there to show that there's evidence-based programs or current existing programs through in the juvenile justice system that are working to keep people from entering the criminal justice system as adults? So those are my thoughts on what we should be looking at in the future. So thank you.
Thanks, Raylene. I see Brian and Peter. Brian, did you want to respond to that, or?
I just wanted to mention at the overall task force meeting yesterday, and Peter, why don't you talk about the formation of a work group to address a definition of recidivism, and that can you just give us an update real quickly on that?
Absolutely. Yesterday, I presented a 3-pillar framework for defining recidivism. Not that this is my area, but I was able to begin a conversation for us to really get into how we define recidivism throughout the system. And we got volunteers, all-star list of volunteers to continue working on this. Dean White, Tasha Thompson, Alexis, Raylene, Birdie, Judge Jones, Maya Vanyo. And then, of course, we had in the meeting before that brought forward a list of all the diversions, and we have a lot of work to do to make all these definitions. And I'm seeing us all going on a variety of tracks. And so, what I'm going to suggest is in the next steering committee meeting, we really tackle this and divide and conquer, because we have a lot of work to do throughout this year, I think, in this very area, and we don't want to be we don't want to be overlapping where it's unnecessary. So I think steering is probably the best place to have that conversation. So we'll put it on the agenda. And I want to just thank everybody on this call for all of your interest and passion around trying to get this right. Because if we don't have the data, we don't know what the definitions are. If we cannot steer this very important ship and help the very people who need to be helped here. So I think steering is a place to have that conversation. Then we'll lay plans for the year. What do you think?
I couldn't agree more that I think if steering is able to define the parameters and membership of these work groups and the particular topics, I think that would avoid a lot of overlap and duplication.
Yeah.
So
And see, Cedric, oh, wait, sorry.
No, I personally, I would welcome that.
Cedric, can you, let's see, Bertie is on your committee, right?
Bertie and Dean both are.
Okay, excellent. Yeah. And Dean, we're going to want to make sure you're in that steering committee meeting as well. I know Bertie will be, so.
I heard you mention Dean's name earlier.
Yeah.
As part of the citizen work. But yeah, Bertie definitely is as well.
Okay, good.
Okay.
I was just curious, Dan, do you have any comment, Dan or Raylene, on what Peter mentioned and kind of putting this on to steering? Do you have any thoughts on that?
I think we built Raylene, go ahead first. I'm sorry, I kind of jumped in there.
No, I'm thinking that's a great place to start, and then we move from there.
Perfect. Yeah, I guess my thoughts are we've taken considerable time and energy and thought to build this structure that we have with the task force, and to let's utilize the structure that we have. That's really it. Okay. Let's see. Okay, so we are almost at time here. It's 12:54. If there are no other thoughts on the on this kind of very preliminary list of topics for 2026, I want to move us on. We've got other business and public comment. So are we good here on just head nods on the 2026? Okay, perfect. Okay, so other business for these committees. Okay. All right, I'll continue to move us along here. Jill, do we have anyone in the waiting room or the attendees for public comment?
Peter, do you have anyone in the room with you today?
No, I'm all by myself.
Okay, and we have one attendee, Marty. If you would like to speak to the committees, please raise your hands now. And she has not raised her hand. Thank you, everyone.
Okay. Well, good. So we're going to give you 5 minutes back to your day. We definitely appreciate the time here today. It was a robust discussion on Digwalich and the other items, and we will get those the meeting schedule in front of you for our respective groups in January. So if there's nothing further, we are adjourned. Thanks for coming.